at any age. Let's say everyone's healthy. Will they lose any kidney function until the day they die? Will they lose kidney function? Yes. Okay. So we start losing kidney function no matter how healthy we are. At what age do you think we start losing some function? Just give me a number. You can guess. It's fine.
10.
10, 40. It's the 40s. So at age 40, we start losing some kidney health. It doesn't mean we're going to end up on dialysis. That's just the way our body goes. That's aging. Sadly, as we age, our kidneys will start to lose function. That's the point, again, where we have to be on dialysis. Those who are on dialysis, probably because they had high blood pressure, high blood sugar, and it was uncontrolled for a long period of time. Not a short period of time, but a long period of time. So a lot of the causes for anyone to end up on dialysis is probably because they didn't have the right guidance on how to control the blood sugar or the blood pressure. Of course, they're also probably using drugs or smoking of that sort, or a little bit of everything. So, and some of it's genetics. Some of it's not even diet, it's genetics. Some of it has like a genetic predisposition, polycystic ovary, not ovary, polycystic kidney disease. So there's also genetic things as well. So the other things that I have to go over with the family as well, because not just the patient I'm talking to, but it's also the family. Because patients that have family support, they also have to know what to cook, what is good and what is bad. And so leading into what I'm talking about, these are the things I have to do, or every dietitian has to do. Appetite and look at ask them if they're doing good, are they vomiting, are they having nausea, diarrhea, all that sort. Now the reason why is because on dialysis, their blood is being cleaned, right? But it's not a perfect process. We take out toxins, but we're also taking out vitamins and minerals. If they're not eating, if they come to treatment as they're supposed to 3 days a week and they're not eating, they're going to get sick every time they come in. Not because of we're cleaning the blood, but because they're taking all the good stuff too, and they're not replacing it with food. So it's my job to make sure that I'm assessing them, making sure that they have a good appetite and they're taking vitamins. So what can be good can also be bad for these patients. So if you hear any of your patients tell you, hey, I'm not eating, I have no appetite, that's a red flag, because they can start to decline really fast. So it's important to let the dietitian and also doctor and nurse know, because that has to be something that needs to be escalated. So, and of course, other things like dentation, do they have teeth? Are they able to chew their food? Do the dentures move? Is it uncomfortable? It does affect the way you eat. Who here's ever had like braces before? You guys ever had braces before?
I have.
You did? I have. So having braces at the very beginning, those middle would suck, because when you put it on, for the first time, your teeth feel really sore when you bite. Anything, it hurts horribly, terribly. I'm not sure if you felt that when you first had them, but it did for me. And all I can eat was soup. That's all I can eat. So dentation is important for also the patients. Some of them don't have any teeth, again, or their partials or dentures move around too much. So anorexia, dysphagia. So I have to look at all these things, because all these things play a factor into their health while they're dialyzing. So renal nutrition, of course, the nutrition will change with the type of modality. So for home dialysis, they strictly limit fluid, sodium, potassium, and phosphorus and carbs if they have diabetes. For peritoneal dialysis, which is PD, and short dialysis have fewer limits, so that means they can have a bit more phosphorus and potassium foods because they're constantly dialyzing. Do all of you know the difference between in-center dialysis and peritoneal dialysis? Yeah. Yes. Good. Okay. Yeah. So the difference, if you're not sure, PD they do it every day, meaning it's like our kidneys. We're constantly cleaning our blood. In-center they only do it 3 days a week. So that's only 3 hours, 3.5 hours. So it's about 10 to 12 hours a week of cleaning versus 40 hours a day, 40 hours a week for PD. So that's why the diet isn't as strict for a patient on PD than someone who's in center or doing home dialysis. Of course, nocturnal, the limits are not as strict as in center because they're dialyzing a lot longer. So, but of course, Phosphorus supplementation is going to be important, and then I'll go over that in a minute. So lab values. As dietitians, we also have to go over lab values for patients, but it's very easy to go over it with them all in a few minutes. But I usually try to talk to them and see what they're focused on. If they're not focused on their potassium, but they're focused on their phosphorus, I talk to them about phosphorus. So these are numbers you guys will have to know as well. These are by the KDO or KDOPI guidelines. Albumin, which is protein, about 4.0. Potassium between 3.5 to 5.5. Phosphorus, 3 to 5.5. What's 3.5, excuse me. Calcium, 8.4 to 9.5. Parathyroid, 150 to 300. This is a little more strict. Other centers have it up to 600, but these are KDOPI guidelines. So these are the strictest guidelines, for good reason, but they're pretty strict. Calcium phosphorus product, less than 55. Hemoglobin A1C, a 3-month blood sugar average, less than 7%. And interdilated weight gain, also something we focus on heavily in the clinic, less than 3 kilograms. Pretty much that's monitoring their weight, and I'll get into that in just a minute because it's a lot of things going on. So there's a lot of things that we have to process and juggle between every patient. Every patient's different. Everyone's different. So any questions so far on what I've shown? Any in terms of the guidelines? Any questions so far? Any curiosity on anything? No. Okay. So one of the macronutrients we look at are nutrients is calories. They gotta have calories, right? So again, going back to their appetite, they're not eating good. They're gonna start feeling malnourished. Malnourished is a big key factor for us dietitians. Even in hospitals, the first thing when the patient comes in, if they're malnourished, they're flagged instantly, and a dietitian has to see them because a person malnourished is more likely to end up in the hospital and in the hospital for malnutrition, and if it doesn't get assessed, they're there a lot longer. So nourishment is important; it's key. So this thing goes for the patient dialysis. We got to make sure they're eating their carbs, they're eating their calories, they're eating their protein. They gotta have it. Protein also makes up our immune system as well, right? Our hair, our skin, our nails. So you gotta make sure they're having their calories and the healthy calories. So the list I have in front of you, you're gonna see all the foods that are labeled okay. They're labeled okay, they're safe. So you're gonna see it's all in categories: fruits, vegetables, protein, condiments. All those are labeled safe for them. So these are considered the safe calories. Of course, this list will always change, and it's not really this is set in stone because if you look under, let's see, I think I have it on the second page. Breads and starches. So on the second page on breads and starches, on the top left, it's bread, except brand. But that's not very specific. Not every bread is made the same, right? There's some bread that's really salty and some that's not as salty. So this is not like really like it's a set in stone. I have to be very specific. But this is to give them a general guideline of what they can have. So usually I go into specific with patients. Everyone's different. So calories is important, and protein is also important. So name me some protein foods, please. I'll go ahead to start saying foods that have protein. Chicken.
Meat.
Steak, meat.
Eggs.
Yes, 12.99. That's expensive.
Fish.
Fish.
He knows the price.
Yes, it's crazy. Tofu, tempeh, seitan, which is like for those who are vegan and those who eat tofu, that's totally fine. Beans and lentils as well. So, and if actually that should be listed. So you look on the good list, all the foods you can eat. It's on the first page. You'll see it there as well. Now on there, you will not see beans and lentils. They are good in protein, but the problem with those is that they have potassium, which I'll get into in another slide. I'm not sure if I put that in your packets. Did I? I did. Okay. So if you go to the third page, you'll see have potassium foods. But so you'll find beans and lentils in there, but not every patient is the same. I might tell them avoid beans and lentils, but what if the potassium is low? They can have an avocado. So everyone's different. So it's important for me to like every dietitian to individualize and cater specifically every needs to every patient, because everyone's different. Everyone's gonna be different, everybody. So, of course, protein, again, gives energy, again, with the hormones, the growth factors, antibodies, fight off infection. And so it's still there, perfect. One thing, I don't know if you guys remember albumin on the other page, has to be above 4.0. The keto guideline says 4.0. When it's 3.6 or lower, they're at higher risk of being hospitalized and higher risk for passing away. Mortality risk it jumps drastically. So every drop in their albumin is a higher chance of them actually passing away. So again, eating protein can help their protein go up in their labs, but not eating protein sometimes not enough. Sometimes what can affect patients' albumin, what I'm referring to is this one right here, albumin. What can be affecting that number? If, let's say they're eating chicken, beef every day, breakfast, lunch, and dinner, and their albumin is 3.6, then it's something else. It can be an infection, whether it's an infection in the gums, if they're sick, they're fighting off any kind of infection. If they have high blood sugar, that will also drop. If they're coming in with a lot of fluids, which they will gain, edema, you'll notice the swelling, albumin will drop. So sometimes it's not that they're not eating enough protein, sometimes it can be other things. So the other things I have to take into consideration and ask the nurses and assess the patients. So again, going back to assessments. So, but on dialysis, they can have a lot of protein, 1.2. For someone that's not on dialysis like us, we can have 0.8 kilograms for body weight. Dialysis 1.2. Because again, what's going on during dialysis? What are they losing? Nutrients. They're losing protein, right? So that's why they gotta have a higher intake of protein. But before going to dialysis, they were all told cut back on protein, right? To let the kidneys rest. They're told don't eat too much chicken, don't eat too much beef, cut back on the protein. Once they're on dialysis, it's the opposite. They gotta have a lot, almost double. So there's a higher need for protein. Okay, so high biological value, which is going to be, again, as you already mentioned, beef, fish, chicken, turkey, eggs, and as you saw on the list there. Then low biological, which is going to be the vegetables, legumes, starch, and grains. They might be low, but they're still important. So, yeah. So any questions on the protein? Pretty straightforward. Yeah? All right. So, of course, eating protein does result in urea, right? We pee it out, the BUN. And it's a byproduct of not only eating too much protein, but also muscle breakdown, right? So when that starts building up, it can lead to low appetite. That's why patients, not all of them, but some of them, when they start missing treatments, and you start noticing that, hey, they're not hungry, but they're missing treatments, is because they probably have a high creatinine level in their blood or urea, and if it's high in their blood because they're not getting it filtered out, they're going to lose appetite. That's our body's way of telling us, hey, there's too much toxins in our body, stop eating. What you're eating is making it worse. So if they try to force themselves to eat, they're going to throw up. That's the body's natural response. So it's important for them to not miss the treatments at all, because they will start to lose that appetite because of the same reason. The urea starts building up, the morning starts building up. So of course, for us, our kidneys can move it, no problem at all. So high BUN and creatinine levels can mean inadequate dialysis as well. So let's say if you're assessing the patient, they come 3 days a week or 4 days a week, and this is high, there's something wrong with the access or the catheter. But that's something the nurse will look into. But yeah, this is important. So we're fortunate that our kidneys still work, protect them, nurture them. A lot of patients, I hear it at least once a week. Hey, give me your kidneys, please. So yeah, protect your kidneys. So what else we have going on for protein? Again, less than 4.0 raise the risk of death on dialysis, as I said. So I went a little bit ahead, but it's right there. The smaller the number, the lower it gets, the worse, the more likely they are to pass away. So.
What's the lowest you've seen, Jonathan?
2.7. That's someone who was nursing home and we're not eating. So when I get to, at least in the next slide, it's going to be given intradiabetic protein nutrition, which is given via during treatment through the machine and straight into the blood. They don't have to eat anything. But yeah, those are extreme cases, and we do, again, we take every case serious. So what can be caused by low protein? As I was mentioning before, diabetes, metabolic acidosis, loss of nutrition from dialysis, again, dialyzing, which is normal, which is healthy, but if they're not eating, they're not replacing, again, this will also drop too. Inadequate dialysis, the diet is too strict. I have one patient that actually had it super strict right now, and she's new, she's young, and she took it to the extreme, which is great. But now that's all the lab results is too strict. So I tell her she has to loosen up the reins a little and eat a little more of the foods that are on the avoid list. Poverty, yes, see that a lot, and then less liver synthesis or more or breakdown. So these are causes of low albumin. And smoking. Smoking can actually cause it to go down. So malnutrition, uremia, as I was saying, uremia decreases appetite. So this can happen if they start missing treatment. So it's important to educate your patients. And a lot of them will say, oh, I feel good. I'm feeling good with 3 hours and a half. And they have the doctor decrease my time. The problem with that is if they're good at 3 hours and a half or 3 hours and 45 or 3 hours and they want to reduce their time, they're gonna start feeling sick because they were good at 3 hours or 3 hours and 30. So it's just, again, making them realize that time is working for them. But it is exhausting sitting in a chair for 3 hours, 3.5, 4 hours. That's very exhausting. It's like sitting in a plane, not getting up. So just keep that in mind, reminding them to stay their full treatment and not miss treatment. Age, depression, lack of moving food, mobility to cook, gastroparesis, because of pain, comorbidities, HIV, cancer, these things can affect a patient's nutrition status. And I've seen it all. I've seen all of it from patients living on the street, and they still come to dialysis. So, and there are social workers. They get involved also and help them with finding resources such as housing, assisted living homes, and things of that sort. So, yeah. Questions on anything right now?
What causes the BUN and the creatinine to change, that fluctuate?
Oh, good question. So depending on how much protein they eat is one of them, because creatinine is a byproduct of not only muscular movement like muscle breakdown, but also eating a lot of protein, and also maybe they're not dialyzing enough, or if depending, then the dialysis is not enough. They need more time on the machine. It's the diet. I'm trying to think of anything else.
You said axis.
Access issues, recirculation. Do you guys know about recirculation? I don't know if I'm jumping ahead. Recirculation is when the needle, if they have a fistula or a graft, the needle is too close. The clean blood is mixing the dirty blood. So if they're going to the machine, it's not really fully cleaning the blood. That can also be a big one. And then the only way to see the recirculation is looking at the labs. So it's good to have a dietitian, especially a nurse who looks at the lab analytically and see those things. So to see, hey, maybe there's something wrong with the axis. So there's a lot of things that can change that. Good question. Yeah.
You talk about the smoking.
Yeah.
So you know the mechanism of the way the smoking is changing. But then I want to know how smoking is working. You talk about smoking.
Yeah, smoking can lower the protein, the albumin, because it's put in a form of inflammation.
Ah, okay.
So smoking is when you're smoking, inhaling, it's like an irritant. So when there's anything irritant, your body reacts to inflammation, despite this all. But that's how it reacts. It's the same thing with high blood sugar. Perfect example, not for something similar to smoking, but for high blood sugar, when the sugars enter blood, do you think the sugar that we consume gets softer, or does it stay just as hard? You think it just dissolves, gets super soft?
Stays hard.
Stays hard. I thought it was soft. once I was working with patient diabetes and I worked in the Texas Diabetes Institute, focused purely on diabetes. I learned that actually the sugar, the glucose in our blood when it's high, that sugar doesn't get soft, it still remains hard. So imagine all these little tiny granules that we don't feel in our mouth, but our soft blood vessels and our veins and our arteries feel it, starts to scratch. And then eventually starts to cause like blood clots. In a way, in the future, if it gets like that. That's why patients have poor circulation issues. It starts having blood clots, I guess the word. There's another word I can't think of right now, another medical term. But yeah. So going back to the smoking, it's an irritant. Your body will register it as a state of inflammation. So albumin can drop. Yeah.
Protein powder is help.
Yes. Yes, there are some protein powders that are good. All of them are so good. There are some better than others, specifically tailored to dialysis patients because it's lower in phosphorus and lower salt. But there are some good ones. So, good question. Usually we promote, I think it's called total protein or whole complete protein. I think it's called complete protein. But there's tons of products on the market. So I believe complete protein is one of the ones that we suggest. I haven't done it in a while because a lot of the patients I talk to, I encourage them to please eat. The best place, actually I love that doctors tell me just push eggs on the doctors. If the doctors tell me to push eggs on the patient. Right now it's expensive, so it's difficult, but eggs are great. Whether it's egg white or the whole eggs, that's fine. Cholesterol doesn't really affect the total cholesterol, the eggs. Maybe the weight, but it doesn't really affect their cholesterol levels. So what can affect their cholesterol levels is if their sugars are high. So, and if you're eating a high fat diet. So, that was it. Okay, so we're on dry weight gain. So we went from malnutrition to dry weight gain. So one thing that's important is when you start seeing patients come in, you're gonna get them to weigh themselves on the scale when they come in, and then when they leave, also weigh themselves. You want to see how much fluid is being removed and how much was gained from the last treatment to where they're about to start the treatment again. So it's important to see if they're losing weight or they're gaining weight. So we'll get into that in just a minute, just like a little segue. So tips for dry weight gain. So if you want to gain weight because they're malnourished, they're not eating enough, or they just want to gain weight and they cannot, pretty much sugar on fruit. My favorite one is actually, where is it? Here's another one. Oh yeah, the gummy, the candies. So Jolly Ranchers, gummy bears. So whipped cream on desserts. So gravy sauces, applesauce. So these are little things that can help them gain weight if they're struggling with weight gain. So I mean, a lot of us don't have the issue. A lot of us have the issue of trying to keep off the weight. Some of these patients are trying their best to gain the weight. So the skinnier they are, the more risk they also. The skinnier they are, the higher risk they are of breaking the bone. Especially when they're phosphorus and PTH, which I'll get into just a minute. When that's out of control, their bones are very fragile, very weak. So it's important for them to gain healthy weight, but just keep that in mind. So I just give them little tips. Internal nutrition. So when I was mentioning, let's say a patient is not eating good, they don't want to eat, and they're coming to treatment, they're very unstable. We offer something called interdietary parenteral nutrition, IDPN. And so many dietitians, we get started, doctors sign off on it, and of course the insurance has to prove it. So I believe that's part of the next slide, so I went ahead. Yeah, I did. So I'll just jump back to it. We give this to the patients. You will notice that not every patient will get it. They have to qualify. They have to meet the criteria of low albumin and a low BMI, low body weight. The insurance won't, again, they're very picky. So I have to make sure that they're not eating. I fight for them. I fight to make sure they get this. In-center dialysis gets this easier than those who do peritoneal dialysis. For some reason it's difficult, but just know that this is really good for them until they're able to regain their strength, until they're able to regain their appetite. Once they have their appetite again, then we can remove it. No problem.
Have you found insurances that won't pay for it? Absolutely.
Kaiser.
They will not.
Nope. Will not. Neither will the VA. The VA. I know, right? It's like the VA, protect your veterans, but they do not want to cover this. At least they do provide the Intero drinks, which are these, Nepro, Novosource, Enlive, Thinner protein powder, whey protein powder, there you go. So, you're on the elevator. So, liquid cell, so they do provide those, but some insurances just don't want to cover it, so they just give this. But if the patient's not eating anything, not able to drink anything, it's gonna be tough to get them this. So this is more of a direct straight to the blood into their stomach type of treatment. So I guess this is my kind of prescription, the things that I can do. Doctors are all on board, but they need a dietitian to initiate this process because they're busy. They have tons of patients. This is driven by the dietitian, intradietary protein. And it does provide our amino acids, which is protein, dextrose, which is glucose and sugar, and fats. Only when they're underweight. So this one is not given to every patient, only when they're underweight. So, and again, glucose is given. The reason why they're given glucose in this protein bag, not just protein itself, is because when the body gets calories, it's going to use it right away. It's going to break it down. So we want to make sure the body uses the protein and stores it and uses it where it needs to be. So we give it glucose. So when the body gets that extra calories, such as sugar or glucose, it uses it up as energy right away. And it leaves the amino acids alone. It leaves the protein alone. So the body can use it and can help the immune system get stronger. So that's why these two are given. So in terms of nutrition, again, it's all these supplements on here. It doesn't replace a meal. And it's given to patients. I'm not sure how other clinics do it, but DaVita, whereas where I work, we provide them these options. We give them Novosource, liquid cell, and a protein bar. Either or, they get to choose. And they only get it if they have an albumin of 3.7 or less. So if it's 3.8, then we'll qualify. And they get it until their albumin is 4.0 3 times. Every clinic, every company does it differently. I know they do. But they do offer it because there's a benefit. So if they're not eating, at least they'll get something in the clinic. So again, this is just preventative steps to make sure that they get their extra protein.
What is Novosource?
Novosource is so good question. So Novosource and Nepro, one is by Nestle, one is by Abbott, and it's pretty much a 500 calorie shake, 8 ounces. So it's like the size of your fist, but loaded with calories, loaded. It replaces a meal. That's what it is. One of our clinical coordinators was, I had samples from Nepro. I believe that one is Nestle thing. They sent me boxes of samples, and I forgot how many I had them in the other office, and they're about to go back. So I wasn't gonna give those to the patients. Well, she was drinking them. She gained weight so fast. And she's like, why am I gaining weight? Like, well, you're drinking Nepro. I mean, that's 500 calories. If you're drinking this thing and you're eating, you're gonna gain weight. So, she stopped. It's calorie dense. So if you compare this, have you guys heard of, what's it, Boost? Glucerna, right? That's the diabetes one. Compared to Nepro, that's a lot lower. So Boost Glucerna is great for diabetics, but problem is that's very low protein. Nepro is higher protein. And the Glucerna, those have a lot more liquids than Nepro. Nepro is a lot less liquids, meaning less water. It's more nutrient dense. So that's the difference. That's why these are a lot more expensive to get because they're not only they're a formula, but they're very dense in nutrients. It's not just water and a little bit of protein powder. So and usually a case of either or of 24 bottles costs about $100 for just 8 to 12 ounce bottles. It's a lot of money for just 24 cartons. So these are something that we only resort to if they're not eating. And again, we offer it to patients when the protein is low. So, So now potassium. This one's also important too. So questions on the IUPN, intradietary protein nutrition. So potassium limits. This one is also important, very important. Potassium limits. So do you guys remember the range I know I went through it really quick. Do you remember the potassium number from Kidoki? Do you remember? I'll give you a hint. It ends with 5.5. Well, what does it start with? 3.5. Exactly. So potassium, we usually look at the labs. If they're between 3.5 to 5.5, they're good. So if the potassium is really high, we gotta start asking them to cut back on these potassium foods. So if you go on this packet that says all the foods you can eat, all the potassium foods, high potassium foods on page 3, oh, the range is on there too. Those are the foods most commonly known to have a lot of potassium. A lot of the foods that we grew up to love and love. So a lot of it does suck to know that you can't have this, especially if it's high. Papaya, oranges, avocados. So potatoes, sweet potatoes, beans, and lentils. So this is a difficult thing to take in, especially for a patient on dialysis if they're new. And I give them this list, and I said you have to be careful with this. You have to limit. I mean, yeah, it's not really the greatest news to hear, especially in your first day of dialysis. So I have to find ways for them to substitute. Like for example, okay, they cannot have oranges on there, right? Let's go oranges and oranges, but they can have mandarins, cuties, the little small ones. Once a day is fine. So it's a lot lower potassium. So these are the things that we have to be aware of. So of course, those of too much potassium is the list right there. Salt substitute is another one. Salt substitute is not very common, but it's called new salt. NU is spelled NU and salt. Some patients do it because they're told, don't eat salt, don't eat salt in your food. So they find a salt substitute called new salt. But that's high potassium, ridiculously high. And it tastes nasty. So I tell them to try MSG. So get rid of the salt, use MSG. Monosodium glutamate. It's a lot lower in sodium. A lot lower. And it does flavor the food good with a lot less sodium in it. So let's see. So potassium, of course, is an important mineral in our body. It helps with the smooth muscle contraction of your muscles, our heart, everything. So when it goes high, and it says right there, it causes heart contractions to slow, and in extreme cases, can cause the heart to stop, cardiac arrest. And if it's slow, tachycardia. Heart going, just irregular heartbeats. So potassium is also important. So the second we say high potassium, it's a flag. Hospitals, when the patient in the hospital has one of these conditions, whether it's high or low, they freak out. They immediately treat it right away because it's a life and death matter. So it's important. And this is what, and the reason why, again, going back to individualized dietary plans for patients is because I tell everyone, avoid potassium, but what if I have those patients that have low potassium? They're causing more harm to them, right? Like, okay, and every patient, I can just easily go around and tell you, avoid potassium, here you go, now look at your labs. But if one of you have low potassium and you're avoiding this, you're actually gonna end up in the hospital with cardiac. So it's important for me to look at all the labs as well. So, and it happens. Sometimes we just become routine and we tell patients, "Oh, avoid it," but we can't say without looking at the numbers. So, and they like hearing the news that they can have all this food again. I'm like, "Oh, have it. It's low. Have it." So have a banana smoothie. Go crazy with it. So ways to limit potassium levels. Go to treatment, right? It's being removed. Go to treatment. Make sure they stay for the full entire treatment. Limiting it on their diet, potassium baths, and the medication called Kexalate. Actually, you know what? I did have the medication here. Oh yes. Okay. So I have Lucalma Veltassa. I don't have this one. I don't have Kexalate, but it's a powder. So this is given on non-dialysis days, and they're orange flavored. Not really the best, but this is given for those patients who constantly have high potassium, constantly. So there are medications.
Is that the binder?
The powder, Lucalma,
Right.
And Veltassa.
Those are binders or what are they?
Diuretics, I believe. It's more like pooping out potassium. Yeah. So what this
Similar
does,
to Kexalate.
yes, exactly. Just like Kexalate. So this will make them poop. They're like, well, how is lower my potassium? Well, it's gonna make you poop. Because how else are you gonna get rid of it? You can sweat it out, but you won't sweat out that much. The other way to get rid of it, dialysis and pooping it out. So this will give them some diarrhea. So are some medications for high potassium. The low potassium, again, just eat it. Yes.
How much is KFC?
The price?
Yeah.
Oh, I do not know. Probably not cheap.
I
So,
don't know because I have never seen that kind of stuff.
What is the name of it again, sorry?
good or less. Let's see. It's this one, the Localma, L-O-K.
Who pays for it, Jonathan?
E-L-M-A. The insurance.
Okay, so it doesn't matter how much it pays.
Yeah, exactly, the insurance covers it, and if it doesn't, if the insurance doesn't cover Localma, we push for Altasa. If it doesn't cover any of these two, Paxilate. Paxilate is the most basic one. So, all right, so if you guys want to know medication doses and everything, there's an app called Good RX on your phone. You just download Good RX. I looked up Localma. 30 packets of this one cost $800.
Wow.
Whoa.
866, 889.
What percentage of patients are on this on a routine? Yeah, about
At least
10.
10, but at least 10%. But yeah, there's some patients that have it high. And yeah, a lot of patients have potassium, so they're on this medication. So this is hurting the insurance pockets too, you know. But in the end, it's the well-being of the patient that matters. So yeah, and the task is probably the same or more. So these are expensive medications. So dialysis is it's not a cheap treatment at all, and it's life-saving. That's why everything's expensive. It's to save the life and prolong life a lot longer. Without it, they wouldn't be around as long as they would have to be. So potassium or salt substitutes, hyperkalemia may occur during the weekends, of course, because they're not dialyzing. So the one thing I want to mention here, lower potassium baths. This doesn't mean that we're gonna tell them, here's soap and bathe yourself with it. It's literally a gallon. It's like a little 5 gallon jug. 1 gallon jug. I mean, 1 gallon? You guys use
For the,
for the baths?
yeah, 1 gallon.
1 gallon, 1 gallon jugs.
If we're using just the pre-mixed jugs, yeah.
Is it pretty much jugs? Yeah, those they connect to the machine, and depending on the concentration, it lowers it. So as the blood goes to the machine, it pulls out potassium out of the blood. A lot of, at least where I work at, that doctors are not pushing for this anymore, unless the potassium is like 7 or above. If it's 6, medication. If it's above 7, medication, and they get this during treatment. The reason why is because while they're dialyzing, the potassium will drop. And then we have this bath that really drops it, like pulls it down, and that can cause issues with the heart as well. So they've been studies showing that this can be dangerous to patients if the potassium is moderately high. So if it's very high, it's okay. So doctors don't really push for potassium baths. But be aware, if you see that there, it can be for potassium, it can be for calcium too. It can be many things, but this is a solution to lowering potassium. Oh, and also, here's another one actually. This is an important one. Let's say your patient, let's say your patient had low potassium, very low. There's a bath to increase it. There's a 3K bath. So if it's low potassium, you give them a potassium bath to increase it. Let's say, okay, cool, potassium is normal, we forgot to check, we forgot to remove it. All of a sudden, the patient's potassium is high. We're like, what's going on? Oh crap, we forgot to remove the potassium bath from prescription. That's a very common mistake. When nurses and dietitians are not looking at the prescription, we give them a remedy. It helped, we forgot to remove it, and now it did the opposite, and it made it worse. So these potassium baths are just temporary. So it's always important to know that when this is done, lab results have to be checked right after that. Again, because potassium changes every day, every treatment. So we check every week. So if a patient on potassium bath, we have to check their lab results the week after to see if they still need it. So keep that in mind. That's also really causes high potassium and low potassium. Question on potassiums? Questions? No? Alright, so, calcium, that one's also important, very important. There's medications to control calcium. It's a mineral that keeps your bone healthy, obviously. It enables muscle and nerve to work properly and blood flow. So these are the guidelines, 8.4, 9.5, very strict. I love it though because this is a metric that a lot of clinics are measured by, even by the state. So 8.4, 9.5. And that is our medication to control it, which I'll get into in just a minute. But what can cause hypercalcemia, high calcium, stomach irritation, confusion, calcification of the blood, and hypocalcemia can cause tetany or painful muscle spasms. So I've seen confusion and I've seen irritation. The problem with high calcium, this calcification. Does anyone want to guess what that means? Want to guess calcification? I don't have any pictures of it.
I showed him some.
Big bone.
Oh yeah,
Yeah, I showed him calciphylaxis.
Yeah.
calciphylaxis. Yeah, it's nasty. And this usually happens, of course, with high phosphorus. High phosphorus or very high parathyroid, IPTH, hyperparathyroidism, which actually is a diagnosis for every patient. Hyperparathyroidism. When phosphorus and PTH is high, calcium is ridiculously high. And what happens is when it starts to float around your blood and there's too much, your body can't store it or remove it, it starts to go in places where it shouldn't be. Your specifically soft tissues. There will be some patients, you notice their fingers are fat, they got a bump here, or parts of the body where it feels like it's stiff or like really hard. That's where a lot of extra calcium is just building up deposits. The problem with calcification also is that they are less likely to have transplant. When the doctors when they get to the point where they wait 10 years, in California it's about, LA it's about 10 years, waitlist for just a kidney. If they see calcification, it probably will be like, I don't want to touch you. Because they can bleed on the operation, on the surgery table. And they won't do anything to them. And then say, sorry, you qualified. So it's really sad. So again, I have to make sure the calcium is in level with the normal ranges. And it's important to always just tell your patients, hey, take care of yourself. You want a transplant, you really got to take care of your diet. It's just especially calcium and phosphorus, which I'll get into just a minute. So again, the calcium, this is difficult to avoid in foods because a lot of foods have calcium. And also a lot of labels don't even tell you how much calcium is in it. But I do have a general list I did not bring with me. So yeah, but the important thing is calcification. Remember that word, calciphylaxis. So let's see, phosphorus. So when phosphorus is high, calcium goes up or it goes down, depending on how the parathyroid is reacting. So usual limit for standard and center is less than 200 milligrams per day. Other treatment options have higher limits. Again, these are the foods of phosphorus. Meats, natural meats, dairy, it's found in everything. Do you guys remember in science class ATP? Remember ATP? No, ATP, energy, gives you energy. Adenosine triphosphate, phosphorus. Our body needs phosphorus for energy. So now where it gets tricky is when it's in food that's not natural. So in this packet where I give you all the foods you can eat and the potassium, there's the phosphorus foods. So that's the Latin one. There's the limit and there's the avoid side on that list for the phosphorus foods. So the ones that have added phosphorus, not natural, like sodas, sausages, chorizos, hot dogs, hamburgers. The reason why that has phosphorus is because whoever makes and the manufacturers put phosphorus in those food or those food elements so it doesn't go bad. That's why. So again, it's more for longer shelf life. So when we eat it, our body absorbs all of it. compared to eating actual beef, chicken that we cook ourselves, it does have phosphorus, but our body will only absorb up to 30 or 40% of that phosphorus. Compared to something like soda and chocolate, will absorb 100% of it. So limiting phosphorus is easy for patients who have family support, who can cook for them. Some of them are in wheelchairs, and it's discouraging for them to be in a wheelchair, to go to the fridge, get to the kitchen and cook for themselves if they're not able to. Some can, I applaud them, I really do, and some cannot. And the luxury of patients with family support have much better phosphorus levels than those who don't. Again, resources. The fresher the food, the more likely the phosphorus will be under control. So, again, yeah, this was just going over the phosphorus foods that I gave you on that list. Phosphorus and calcium like to balance each other out. So if phosphorus is high, calcium tends to drop. I can go over parathyroid without confuse you guys a little, but I'll get into that in just a minute. Hyperphosphatemia can cause hypercalcemia. So either depending on another lab, if phosphorus goes up, calcium goes up. Sometimes it goes down depending on how long phosphorus is high. So just know, at least basic rules, if this happens, if phosphorus goes up, calcium will go up.
Jonathan, so the going down, is that the start of like precipitation and it's binding with phosphorus? Is that why the calcium's going down?
Yeah, when the phosphorus is high for too long, it drops. Calcium starts to drop. Again, like you said, it's just the availability of it just starts to diminish, but it drops. And especially when parathyroid is high, so the PTH is high with phosphorus, calcium tends to, yeah, it's really weird. And it goes, it's like a case by case basis, but it does happen. But general rule of thumb, phosphorus goes up, calcium will go up, generally. Okay? Now, so, phosphorus. So, again, the range is 3.5 to 5.5 for phosphorus. Let's see, symptoms of high phosphorus: itching, bone and joint pain, muscle weakness or aches, and then bone fractures. The itch is the most extreme one. For patients who've had phosphorus very high for a very long time, they're gonna have this itch that it doesn't go away. It's bad. Have you guys ever felt an itch where you try to scratch yourself but it just doesn't go away, you have to hit it? Have you ever had one of those kind of itches before?
No.
No, it's bad.
I had when I was running,
Okay.
in the back of my legs.
Yeah, so it's like one of those, like you scratch it, just doesn't help you, you have to hit it for it to go away. That's what they feel. When phosphorus is really high, when it's above 5.5, for an extended amount of time, it's just extreme. And it could be any part of the body. And on the scratch the way they bleed. And they bleed. They want to get to it. And it's, again, the phosphorus, if it goes up, what happens to the calcium? It's going up. Where's the calcium coming from? Where's the calcium stored? In our bones. So what they're feeling is calcium leaving their bones. That itch is way deep in there. In order to satisfy it, they have to lower their phosphorus. They have to be careful with the foods that they're eating. Fast food is the most common issue when it comes to high phosphorus, the fast food. So, of course, limiting phosphorus levels by going to treatment, taking phosphorus binder pills, and eating a low phosphorus diet. So these phosphorus binder pills, I actually brought some. So you can, this is the same thing, you can pass it around. I have 3 of those, you can just pass. You keep one and you can just pass it. You can see, look at the size of those bad boys, they're huge. That one's developing. So, yeah, so check them out. Look at the size of those things. It's like a Centrum tablets, right? Okay. They're huge. So the purpose of these, there's different ones. There's, in the market is not, I can't say it's flooded, but there's different kinds. There's, actually the list is on here. I'll get into it just a minute. The purpose of this pills is to suck up the phosphorus when they eat food. So they have to take this when they're eating the food. It's not before or after, or it's not one, I don't want to eat, I'll just take it. It doesn't work that way. This is supposed to help prevent the phosphorus in the food that you consume. Because once we eat the food, this goes along with it. What it does, it grabs onto the phosphorus in the food. Not all of it, it tries to grab a good portion of it to poop it out. Or it doesn't go in the blood. So that's the purpose of these pills. And of course, timing is important, so you always tell them with your food. With your food.
Jonathan?
Yeah.
You said poop like 5 times already.
Yeah.
Any problems with that for people? Like, do they get
Oh.
like, what do you call it, external hemorrhoids or, any issues created from the pooping so much and diarrhea, constipation, like?
Yes, so thank you for mentioning that. Constipation is an issue. Diarrhea, if they're on like medications or the potassium, but usually this one here, this is called sevelamer, the ones you guys saw. This one can cause constipation after taking 3 of these per meal. That's 9. A lot of patients do take 3 of these per meal, or 9, or 4. So, and the phosphorus is ridiculously high, and probably because it's either diet, or they're forgetting to take the pills, or they don't like the pills.
Because it's too big.
They're too big. Imagine taking 3 of these for breakfast, lunch, and dinner. That's 9. So as Michael was saying, constipation can also lead to hyperkalemia, high potassium, because you're not pooping anything out as well. So this is a very common problem too in this population, constipation. So this can be a good thing, but also can be bad. So constipation is pretty common also. Besides the fact that they have to limit their fluids, I'll just mention it right now. The fluid restriction is 32 ounces, generally speaking, for a patient on dialysis in center. I think that one is a 16 ounce bottle? 16. So 2 of those bottles, can you please hold that, please? So everyone see this? 16 ounces. So that 2 of those a day of fluids. That includes tea, soups, ice, jello, any kind of a smoothie and beverages. So imagine having to limit only to 32 ounces and still take 3 pills. 3 of these. It's very difficult. It's like, how can you enjoy your meal? You can't. And then also they are getting iron, of course, because they're very, very predisposed to becoming anemic. So they get medication, iron being one of them. So the iron, the phosphorus pills, the limit of fluids, all that can cause constipation. So a lot of things going against them. If they're not eating fiber or vegetables, which is kind of common in the clinic I work for, that's another thing that makes it worse. So I have to promote probiotics and eating foods with fiber they like. So constipation is very common. Yeah.
What about any of the, like, just damage to the GI? Like I said, hemorrhoids, ulcers, things like anything?
I have hemorrhoids are common. Ulcers will be more like for other reasons, not really these binders. But mostly constipation. But hemorrhoids can be an issue if they're pushing too much. But I haven't heard too much of it because a lot of them don't talk about it. The ones that have opened up is very few. Yeah. So good questions. So different phosphate binders. Oslo, Renal, that's this big one right here. Renal, and Tums. Tums is pretty much the same as Oslo. The difference is one is calcium acetate, the other one is calcium carbonate. So yeah, there's different ones out there. There's new ones out there too that just appeared. So all of you already saw sevelamer, the big white pill. This is calcium acetate right here. Yeah, that one. It's a little bit smaller, but yeah, you can pass this around too. They can do comparison. So there's that. There's also Orexia, almost the same pill as sevelamer, but pink, and has iron. This one has iron. A lot of doctors are not really sharing this one anymore or prescribing it because we already give the patient iron. They don't want to give patient any extra iron if we're managing it already. You guys are assessed on there. And so far, the favorite one from a lot of doctors is Velphoro. This one. This big old coffee looking one. I'll pass it around. Yes, Velphoro is chewable. That one is chewable, and you know what, where's, oh, here it is. So that one is chewable, that one is just like this one, natrium carbonate. So imagine having to take 3 of those with your meals, 3, yeah.
They can chew that one.
Yeah, so that one you can chew. So now the beautiful thing about that,
Damn.
yeah, it's crazy, right? So cut back on your fluids, but still take all this medication. That's not including the medication for the cholesterol, the blood pressure, right? There's blood sugar. It's a lot of things we're asking these patients to do. It's very stressful. So yeah. Oh, thank you. So the one nice thing about you guys saw the red one, right? The coffee colored Velphoro one. That dogs are liking that one, so am I. Thank you. This one is because like one of these is like taking 2 to 3 of these. Cool. So yeah, one of those like taking 2 or 3 of those. So the only bad part about this is their poop looks black. So I just tell them, hey, if you're okay with your poop looking black, this is the greatest thing. Just try Velphoro. But again, some insurances don't want to cover it. But right now, that was an issue a few years ago, now it's not. It's easier to get it approved. So these are the expectations for the patients. 3 of these pills, two pills. It's better to take control of the diet and try to avoid taking these pills. The pills are there to help, but it's not there to substitute like, oh, well, I have these pills, so I'm gonna go eat Carl's Jr. No, that's not what it's for. It's help control the phosphorus. But yeah. Oh, I forgot this one. So you saw all the pills. There's also a powder version of this one. There's also a powder version. So this is the sevelamer red powder. So this one's an orange flavor. Some patients like it, but the issue again, it's a fluid. When you mix it with water, you have to count that as a fluid. So, yeah. So keep that in mind. So there are medications to help them lower the phosphorus. So, questions? Confusion. Yeah, cool. So, all right. So, again, so bone mineral, dietitians were considered the manager for the bones. So the MBD, mineral bone disorder manager. That's what we look at. We look at these: calcium, 8.4, 9.5, phosphorus, calcium, phosphorus product, and then the PTH, the parathyroid. Not the thyroid, but parathyroid. So, and I believe we have those medications in here as well. So, when their phosphorus is under control, usually calcium's under control, and parathyroid is normal. So, for the bones, it's important. There's constant bone turnover. Our bones, as we speak, are constantly reconstructing themselves, breaking down and reconstructing to get stronger. So, one thing I learned a lot through my years in school with nutrition was that patients who actually are overweight or obese have thicker bones than those who are thin, naturally thin or like skinny when they started, because the weight, it's called weight bearing. So all that weight actually makes the bone stronger than someone who is not overweight, I guess, not obese. So those are the ones that tend to not break any bones, which is beautiful. Because when they do break a bone, their health declines really, really fast, and it's really sad. It's really, really sad to see, especially when they're older. Yeah, it's really sad to see. So it's important to make sure that their calcium is good, so they don't break a bone. Yeah, because it's a lot of work for the body to reconstruct the bone, especially if they're in their 70s, their 80s, and 90s, and on dialysis. So, bones are made up of cell fibers, blood vessels, nerves, and minerals, such as calcium and phosphorus. And these two are bound together in the bone. So, if the bone were to release calcium, it's also releasing phosphorus. That's why in the previous slide it said calcium phos product. So, when the bone's releasing calcium, it's also phosphorus along with it. So, how does it relate to bone? How does bone disease relate to heart disease? When calcium is released, Due to high phosphorus, they combine to form this product. This prohibits calcium from going back into the bones. So again, calciphylaxis, right? Calciphylaxis. So metastatic calcification of heart and blood vessels causing them to become stiff and narrow. So one thing I forgot to mention, and I'm glad it's in the slide, stiff and narrow. For blood veins, vessel, arteries, what's their purpose for regulate, what, I already said it, they regulate blood pressure, right? When they dilate or constrict, right? They're supposed to be constantly doing that to control blood pressure. Well, if it's calcified, it's stiff. It's not able to vasodilate or constrict as they should normally, making it difficult to control blood pressure. Very difficult. So they can take all these pills, but if their blood vessels, again, their arteries and veins are stiff, it becomes difficult. And the damage is not reversible, permanent. There are some medications being tried right now in trial to help reverse it, but as of right now, there's nothing to cure that. So again, it's important for me to get involved with their diet and try to motivate them to see the importance of it. So yeah. Again, to the bones, phosphorus is not filtered by the kidneys, high phosphorus and low calcium signals the release of parathyroid. So I think that's the next slide. Okay, I'll get into it. Pretty much, so PTH parathyroid, the thyroid, we have two thyroids, two big old thyroids. Two big thyroids, we have two small in each one, so we have four. They're called parathyroids. So those are, that's becomes very hyper, or it's released when phosphorus is high, or when calcium is low. That tends to go up. So there are medications to lower that, but when that happens again, phosphorus, calcium starts to go to parts where it's not supposed to, calcification. So low calcium in the bone makes them weak, brittle, and similar to osteoporosis. So there are medications that help lower parathyroid. And I'll show you in a minute. So, symptoms of bone disease, bone pain, aches, muscle weakness, fractures, and joint pain. Those are pretty common symptoms. So osteodystrophy implies that the bone strength is, in CKD patients, is a function of bone turnover, bone density, and bone architecture. So adynamic bone disease, bone turnover, weight bearing exercise are important to bone health, weight lifting, jogging, dancing. As I was saying, weight bearing. So, yeah, things you just gotta know. So hyperparathyroidism, the parathyroids, as I was saying. Now there are surgeries to help remove it, the parathyroids. Since I've been working in this industry for 7 years, I've only seen it happen twice, maybe 3 times, where it was removed, the parathyroid. And they don't remove all 4, they remove 3 or 2 of the 4. And that they only allow that when the PTH is just constantly high and medication does not bring it down at all. Like we're giving a high dose of cinacalcet, Sensipar, Parsabiv, all these medications that are expensive and it's not lowering it. Sometimes the doctors will refer to that measurement, but I haven't seen it done. They just try to, a lot of it's caused by the diet, honestly. A lot of it's the diet. If they're able to control the phosphorus, parathyroid should remain within normal ranges. Again, it's difficult to follow such a strict diet. It is very difficult.
Why
But
do
again,
they,
yeah.
question, why do they only leave one thyroid if they're gonna remove 3? Why don't they remove all 4?
I never asked the doctor that question. I know for a fact that when they do come back with that 1 or 2 thyroids, their PTH is drastically low. So remember the range was 150 to 300. They come back with like 80s, 50s, 10s, 20s. It's drastically low, even with that 1 or 2 that they have left.
Well, Jonathan, isn't the parathyroid gland part of normal bone remodeling though?
It is. I never really asked why they keep at least 1 or 2. But it is
What if
part
you
of it.
have no PTH? Will your bone turn over?
It wouldn't.
Yeah, so that's not good, right?
No. Yeah.
Yeah.
Yeah. So, well, we need bone turnover. So, yeah. Hey, want something new? Yeah, usually it's like, I never ask the doctor why. We just stick to like, all right, it's one or two. But yeah, the bone channel is important because the bone needs to constantly reconstruct. If not, I mean, we want the bone after, because like, think of it this way, like our blood lives for 3 months. But what makes more blood? Our bones. Our bones are responsible for making more blood, right? So the bones constantly reconstruct itself to make it stronger. So you know how like a shark loses the teeth and the tooth comes out? It's kind of the same thing for our bones. So the inner pushes out, so the outer is kind of dying away. The inside makes it get strong. So that's what it's called. I skipped it, but bone reconstruction, right? So let's see, PTH, parathyroid symptoms, the same thing, we went over that. Treatment of secondary hyperparathyroidism. So number one, I was telling you, high PTH. These medications, sensitive part of the medication, phosphobinders is the medication. Vitamin D analogs. Vitamin D is this one. Wait, I don't have vitamin D. The reason why we give patients vitamin D is because, here we go. You can pass this around. Vitamin D, when we can eat vitamin D, we can take it by sunlight, right? But the problem with kidneys that are no longer functioning well, the process of vitamin D, it has to be transformed twice in our body. When we eat it, it has to go through our liver. Our liver turns that vitamin D to another form. Then that new form goes into our kidneys, and our kidneys transform it one more time, called doxycycline or calcitriol, which our body can use that form of vitamin D as a hormone. Also, it acts as part of our immune system. But our body can only use that form after it went to the liver and went to the kidneys. Then will the body be able to use that vitamin D? Well, dialysis patients, their kidneys are not working well. So if they eat as much vitamin D as they want, it will not work. It has to be the active form. The active form is what's not on it. It's calcitriol. The pill I was passing around. Calcitriol or doxycycline for the IV. So let's see. And then the other medication I have it here, cinacalcet, but that also helps control it. So active vitamin D found in various foods, and as we know, from sunlight. Just don't stand outside and get sunburned. I think it's about 15 minutes minimum, maximum outside. You should get the max amount of vitamin D through sunlight, 15 minutes. Not behind the window, you have to be outside and get the sun rays. So converting into active form, the healthy kidneys, again, since your body can't do it, if they're on dialysis, they get the active form via pill. So, yeah. Let's see. Zempa or Hectorol, again, those are the injections, if they don't like the pill. And PTH low determines effectiveness of vitamin D dose, of course, yes. So the vitamin D affects the parathyroid. So the PTH, remember, I said it was high. If we give them vitamin D, and it goes down, it's working. So I'm responsible for adjusting the dose for every patient, because they do get it in center. Some patients take it at home, no problem, but doctors prefer doing it in center. So I'm responsible for dosing the vitamin D for everybody, based off the levels. Sensipar, it's a low green pill, and that helps again lower the parathyroid. So, that's this little green pill right here, parathyroid. So, this one is important for them to take with the meals, or at least on a full stomach. If they take on an empty stomach, they will get nausea, the stomach will hurt, and they feel like they want to throw up. So, this medication is strong. That's called cinacalcet, and that helps lower parathyroid. So vitamin D is not lowering PTH. Then we try that bad boy to see if it lowers it. The problem with that one is it will lower PTH, but also lower calcium. If calcium drops below a certain number, we have to stop that pill. So in order to counteract that, we give them more vitamin D, because vitamin D helps increase that calcium. So we give them vitamin D, the orange pill, right? So vitamin D does this. Calcium goes up a little, parathyroid goes down a little, which is great, what we want. That medication brings this down and this down. So we give them more vitamin D, it does this. So I'm playing, like the balancing titration every month for patients on those medications. So I have to titrate every month to see, okay, 0.25 more, point less. So those are things I have to do for the patients as well. So, and the dose is 30, 60, 90 milligram dose pills. But they can take up to 150 milligrams of Sensiform, of that little green pill. I don't really push patients to take that much anyway. I try to help them with their diet and the vitamin D before going to 150. So, yeah, and again, they cause nausea. So I tell them to take it on a full stomach. Questions so far?
I do have one small question.
Yeah.
So when you give the vitamin D to the patient, when they're doing the dialysis, your blood is being cleansed. So if they take that when they're there, is that being cleansed and it's not gonna work for them? Or do they take it once they get there or when they leave?
So it's not really removed from the system. The vitamin one is. But yeah, medication, not all medications are dialyzed, but some are. No, thank you. Yeah, so that's a great question. But it usually takes for medication, vitamin D, kind of like food, takes about 3 hours. I'm not sure for vitamin D, but I know food takes about 3 hours to enter your blood.
Okay.
So, but this is usually given at the end of treatment anyway. So end of treatment, nothing's removed. Okay, good questions. Vitamins A, D, E, and K cannot be removed anyway because they're considered fat-soluble vitamins. Fat-soluble vitamins are not really removed through dialysis anyway because it's stored in the fat. A, D, E, and K, and that's vitamin D. Vitamin C and B vitamins are lost through treatment because it's in the blood, it's water soluble. It's not stored in the fat. So, great question. Sodium. All right, cool. So, the max amount per day for a dialysis patient is 2,000 milligrams of sodium. The American Heart Association, I think, has given us 2,004 or 500 for us, the non-dialysis people, right? So, a teaspoon of salt has 2,300 milligrams of sodium. That's a lot. And the max they can have a day is 2,000 per day. So when they have too much salt, it will make them thirsty and it will make them swell, edema. So on the other sheet that I just passed, the other one with the fast food, the first one is bacon jalapeno cheeseburger. What's the sodium on that one? It might, I hope it says on there.
760? Oh, no, that's calories, sorry.
1620, yeah, it's a little faded, sorry, I have to reprint this. 1620. Well, that's 20. Or just the bacon jalapeno cheeseburger. It's a lot. The max 2,000. Right, yes. Yeah. Yeah, it's nice to reprint it to that. So, that's a lot
Just put one.
for just one hamburger.
That's literally their whole day.
For the salts, exactly. So, and again, the fact that this is fast food, it will have phosphorus, but what makes it very salty will be the bacon, the jalapenos, which also, right, made with a lot of salt, and the cheese. So all that adds up really fast. So these are the things that just have to bring into awareness because they tell me, oh, I only have one hamburger a day. Like, well, which one is it? So I try to help them make some better substitutes. Like, okay, can you go to another fast food place that's better versus avoid them all because some of them don't have that luxury. Some of them don't have the luxury of going home and someone there to help them make a meal. So, but again, this is to bring awareness and they make their own decision, their own choice. On the second page, oven roasted chicken from Subway. Does yours say the sodium or is it cut off?
It's 1390.
1390. Is that the full long or 6 inch? It's under the name of it listed. 6. But it's 13 freaking 90. Right? So, I did this on purpose. I picked all the salty foods or all the salty condiments. So if you check there, I picked Italian urban cheese bread. I chose cheese, any cheese, but I chose the cheese. All the vegetables I chose are made with a lot of salt. I didn't add, I did add salt and pepper as well. So I purposely did that so you can see how easy it is for the salt to go up. So usually for like Subway, go for fresh vegetables. The lettuce, what is it? Do they have bell peppers there? I believe. Let's see. Green peppers, yeah. So cucumbers, there it goes. The cucumbers, the green peppers, the lettuce would be the best options. And depending if they're potassium high or low, tomatoes. So yeah, I compare that to the Subway tuna on the last page. Subway tuna. That one I purposely chose no salty stuff, just a fresh bread, like wheat bread, and veggies with no salt, and no salt, pepper also on top. That is how much sodium?
610.
610. That's okay. The max is 2,000, but 6-inch, no, it's not filling. Depending on the person, right? So again, it's bringing awareness of the sodium. That's what the point I'm making. So I'm pretty sure the chicken one may be lower or the same amount of sodium if I were to have chosen those same ingredients. So again, bringing awareness. So it's very easy for anyone to eat too much salt without noticing it. So yeah. And MSG that I mentioned before, monounsaturated glutamate, MSG, a teaspoon of that has about, I think, 400 or 500, I gotta check one more time, 400 or 500 milligrams of sodium versus a teaspoon of salt, which is 2,300. MSG is a lot lower, and it makes it flavorful. But you guys are gonna hear, MSG isn't healthy.
Yeah.
Yeah, that's true. If you cook it with salts, or make your food with salt, and yeah, it adds up really fast. But MSG isn't there. So, but of course they still gotta measure. I'm not gonna tell them to pour, measure your MSG when you cook your food. So it's just, again, reteaching it to patients and doctors too. I'm making the doctors to get on board with that. So the goal of low sodium diet is to manage hypertension and promote loss of fluids, excess fluids like edema, because the body will hold on to the water when they have too much salt. And when anyone eats anything salty, our body will naturally ask us for water to pee it all out. It's not a lack of discipline. That's our body saying, hey, you have high concentration of salt in your blood, let's pee it out. Dialysis patients cannot pee it out. So if they're doing receiving in-center dialysis, they have to wait till the next treatment to remove whatever they consumed. So sometimes they come in weighing 5, 6 kilos, 7 kilos, 10 kilos. I've seen one time it was about 8, and that was ridiculous. But he was a big guy. 8 kilos in just a day, in 2 days. That's a lot of fluids being removed. Again, the salt. So eliminate salty foods. Fast food, smoked, salted meats, canned foods, pickled vegetables. So again, salty or high salt diet, high blood pressure, naturally. So we just have to try to have them be fresh as much as possible. Use MSG instead of salts, and they will tell you what MSG is unhealthy. Just the thing to do is just have somewhere typed up MSG and sodium versus salt and sodium. Do the comparison. If not, just a dietitian, I'm not educating them. No problem. So extra fluid in the body equals extra fluid in the blood vessels, making blood pressure higher, causes fluids to be retained, creating thirst, and then thus causing the swelling in patients where they have a lot of fluids. Questions on the sodium so far? Questions? Okay. I forgot to mention this. This is important. Hypertension is the second leading cause of chronic kidney disease. So high blood pressure. So just keep that in mind. Do all of you know what's the regular? Okay, if you've never been diagnosed pre-hypertensive, what's a good blood pressure range? 120 over 80. I think 90, but yeah, 80. 120 over 80. Or less. That's okay. Someone who is pre-hypertensive, less than 130. I believe it's 125, 130 or less. Someone who's hypertensive above 130 is already considered hypertensive. Based on dialysis, when they're already considered hypertensive, the goal is 150 over 90 or less. So the reason being is because it's difficult to get into the 120s, 130s. This is difficult. There's medications, but 150 or less is the goal. So just keep that in mind. 150 over 90 or less. And they think that, a lot of them do think that their 180, 190, 200 is normal. I'm like, well, I'm serious. Like, we get them to 140, 150, and they're like, I feel lightheaded. Oh, I don't like it. I feel tired and weak. It's because they got used to 200. But that very same blood pressure is what got them there. 200, 180, 190. They might have gotten used to it, but it doesn't mean the body is used to it. Hell no. No. It's language, but it's not. So, that's again, educating, bringing that reality to them. Like, no, you have to get used to it. It's healthy for your body, for your vision and the nerves and everything. So yeah. So, real quick, the fluids again, a liter or 32 ounces or 4 small cups a day. For those who are on dialysis and center. No urine output, pretty much 4 cups per day. Now, if there are peeing, they can drink what they peed out and then go to the limit of 4 cups. But that gets a little confusing. But just know, usually it's 4 cups a day. So let's see. Generally, intradialytic weight gain should be kept in less than 3 kilograms. So fluids at room temperature, pretty much ice cream, ice, so and Jello. Let's see, make sure I have a little time. So fluid overload, again, edema, the swelling, blood pressure goes up, make it work harder. That's right. The fluids, when you have too much fluids, it goes in your heart and in your lungs. A lot of them will say, oh, I can't breathe, or they're coughing and it sounds like they have phlegm. That's fluids. But they think it's a cough, like, oh, I'm sick. No, it's fluid. You can see it when they come in when they're swollen and based off their weight. When they tell you, oh, well, I eat a lot. Well, I eat a lot and I don't gain 5, 6, 7 pounds in a day. Is this bringing the reality of, no, this is fluids. Are you eating salty foods? It's hard to be critical and non-judgmental, but you have to keep in perspective that these patients are taking all these pills. They got to drink water with all these pills. They have to limit everything they eat too. So it's just coming back down to making them realize, try to cut back on the fluids, or the salt. If the sugar is high, they're naturally going to be thirsty too. So that requires a specialist, a diabetes educator, a visit back to the primary. So, yeah. So when the fluid goes in the lungs or the heart is, you're going to notice the blood pressure is going to be really high, the pulse is high, and so forth. So fluids can affect them in many ways. And when we're removing fluids off of them, especially high amounts, which we shouldn't, but it happens, cramping does occur, blood pressure tanks as well, and they pass out. So it's important to have complementary treatments if they're leaving a lot of fluids. Push for the extra treatments. So, the washed out feeling after dialysis, because it's so aggressive. In 3.5 hours, trying your best to maximize the cleanings, it sometimes will leave them feeling done, tired. Like, I can't. They don't have energy. So, yeah. So tissue fluid control. Avoid salty foods, as we mentioned. Eat small pieces of fruits. Chewing ice can help a little. Some patients overdo it, not too much. Applesauce, the lemon wedges. So brush your teeth. There's something in here. Well, friends. Yeah, no, these would be pretty much the basic tips. One thing I did learn that's not on here, patient told me to get rid of their thirst, they just drink hot water. Not tea, not coffee, just hot water. It's never good. It's not appetizing, so you gotta rid of thirst. Cold water tastes great, we don't stop drinking it. Hot water by itself is nasty. And it helped her. I do get a tip to some patients, and it does help for some. So just hot water in itself or warm water just isn't appetizing, and it helps them not drink as much. Vitamins, multivitamins, it's important to take. They take their vitamins. This one I always tell them take it after treatment because it can be dialyzed. So the reason why I say after treatment is they come in, they dialyze at, let's say for example, 8 o'clock. They're done with dialysis, they get home at 12. So they can take it at 12 o'clock every day. Because if they take it before treatment, there's a likely chance that it will be removed through the dialysis process. As you mentioned before, what about the vitamin D? Vitamin D isn't removed, but renal vitamins, all the B vitamins and vitamin C, like I said, the water soluble ones will be removed. So yeah, it's important that they take it every day. And just basic statistics, basic facts, leading causes of CKD are diabetes. Diabetes is one of the main causes for chronic kidney disease and stage renal disease. And of course, what was number 2? Hypertension, that's right. So, I always lost the topic real quick. So type 1 diabetes is those who why doesn't make insulin, and type 2 makes insulin resistant. So they just have to make sure that they see a specialist just for diabetes. There's a regular doctor, and then there's a doctor for diabetes. It's called endocrinologist. Push that on the patients. They please ask your primary to assign you to, you can say diabetes specialist. It makes more sense than saying endocrinologist because it can be a bit confusing. They can help them with their dosing of the medication. So, yeah, complications of uncontrolled diabetes, nephropathy, retinopathy, neuropathy, heart disease. All this happens because the blood sugar is high. It damages all these systems of the body. So, most people are diagnosed with diabetes by years of the progression of the disease. So therefore, this kidney disease may be present for several years before diagnosis. So if diabetes is better managed, kidney health can be, it won't be as much damage to the kidneys because the kidneys full of little tiny blood veins called nephrons. Nephrons are the blood filters, I can't remember the name. Glomerulus, thank you very much, yes. So they're tiny, very, very tiny. The blood sugar can't destroy all of them, especially when it's exposed to high blood sugar for a long period of time. So all these things do happen with blood sugar that's uncontrolled. And symptoms of diabetes, when tired, hungry, having to pee a lot. Like you can't control it. Weight loss, poor wound healing, or vision. So these are symptoms of diabetes. Just keep that in mind. Okay. I'm not sure how much slides I've left, but.
You're almost there.
Oh, cool. Okay. Yes. So how can you help achieve how can you help your patient achieve better nutritional status? Always refer to the dietitian or the social worker, depending on the symptoms or what the problem may be. But patients require all these professionals: nurses, patient care technicians, social workers, dietitians, AAs, the administrative assistants in the front. It's crazy to think that one person needs all of us, and it does. It does. It's a very complicated disease, a chronic condition, and they need every help they can possibly get. So, if you feel like you're lost, you don't know what to do, always inform us. Always inform a social worker, dietitian, if that's the case. All right, the team is there to support. So, yeah, and always encourage them to be better. One thing is that I love about technicians is that all of you have built that rapport with these patients, whether you wanted to or not. You do. They trust you with their lives. They trust you the fact that you cannulate them. They'll tell you, they're like, oh no, I want you. No, I want you to cannulate me, because that trust is there. So they tell you more than they tell me. or any dietitian because you're there constantly by their side. So usually you guys, all of you are like my ears for me. Sometimes they say something to you, you're like, ooh, let me tell Jonathan. Because sometimes the patients forget, and I understand. They tell you something, then you let me know. Let your dietitian know if they feel comfortable and ask them, can I share this with your dietitian? Yeah, go for it. You don't want to ruin that trust either. Okay? But yeah, we're there to help. Just ask. Any questions before we end today? Any questions? Because that was a lot of information. A lot. Any questions? Yes.
How to know this guy is coming back 2 days? How to know is gaining weight or just whatever? You know how?
Mm-hmm. So the symptoms, usually the nurse has to always evaluate the patient, right? Especially after the weekend, after the 2-day weekend, they gotta check to see if they have edema, if they're swelling. They gotta listen with their stethoscope if there's cracking in the lungs. And if they're in treatment, if pulling the fluids makes the blood pressure drop, they start to cramp. Those little things you start noticing, you start measuring. If they start cramp, low blood pressure, they didn't gain much fluid in between treatments, that could be a sign they're actually gaining weight. If they're cramping at home, muscular cramps can also be a good symptom too. But you can't just say, oh, they're cramping. It has to be weight gain. It can be low calcium too. Low calcium is also muscular cramps. So we can't assume everything. We have to look at the whole picture. A good question. Any other questions?
I have two.
Yes.
So just to add to the cramping, met with some vascular surgeons a few weeks ago and learned more about peripheral arterial disease and the damage that is done to the peripheral vessels, but also about steel, how when we do dialysis, that there's a high demand of blood to the fistula or the graft that kind of says, like, where's the blood needed in the body? It's needed in the fistula or graft.
Yeah.
So you lose blood flow to like peripheral extremities, and then cramps not associated with fluid and things, but actual flow. So that's more of a comment, is that there's a lot of different causes of cramps, right?
Yeah.
It's not always weight gain and excess removal. But I have a question for you personally, Jonathan. You said something that struck me, and I was waiting till the end to ask it, but you mentioned like helping the responsibility you have of helping people to stay within certain parameters and the impact of staying in parameters towards transplant.
Yes.
So forget, I want to kind of come away from the numbers and go to personally, like, how does that feel to have to analyze, create a plan, educate, and hopefully have somebody take? How does that feel, that responsibility that you put it as, helping them to stay in range so that they can get keep on the transplant list and get the transplant?
When I first started as a dietitian 7 years ago, for just kidneys, it felt like a heavy burden. For me, it's like, okay, that's a lot of responsibility for me to watch over 120 patients. There's 120, how many of them are likely to get transplant? And then how am I gonna help all these 120? Because that's how many we're assigned to, minimum 120. So we have a big caseload of these who is motivated to want to move forward and get that kidney transplant. So at first it was stressful. I was like, well, I got responsible for all this stuff, and then this patient really wants a transplant. So what, after the first transplant that I experienced, it felt rewarding. It felt so good to see that, okay, someone took my advice, despite all the things they have to fight through, all the things they gotta do, all the changes they gotta do, the appointments they gotta make, the sacrifice they've done to get that transplant. It's so rewarding. It's a beautiful thing to see someone get a transplant. And that's why I still do it. That's why I continue doing this. It's 7 years. It may be a lot of work, but in the end, I know if someone gets a kidney transplant, I did my job. I help them get to that point, help get to a new chapter in their life. Because when they leave, they come back one more time to say their thank yous, and they would never see them again. And that's what we want them to do. We want them to move forward in life and not look back, but also learn from that experience that, hey, take better care of yourself so you don't come back sooner. So it's a rewarding feeling, but it was daunting at the beginning. But once I got the first transplant through, it's just a rewarding feeling. Yeah, especially when you see it we get that call the next day. Hey, I got transplanted. I'm in the hospital. They call me at 3 a.m. I got it. I'm recovering. Oh, it's a wonderful feeling.
Yeah.
And teammates also. We all celebrate with like, so much joy. The teammates, the nurses, the doctors. Like, it's a beautiful thing to help them go through that process. Whether it's 5, 10 years of waiting for one, it's beautiful to see that happen.
Thank you, Jonathan.
Let's give Jonathan a hand, guys.
Thanks for being
Your
here.
information.
Yes, it's a lot. I do have a Dallas YouTube channel. I just put cooking recipes. I haven't posted anything recently. I've been very busy. But I do post cooking recipes for Dallas's patients.
What's his page called, guys?
Diaz is approved.
Yeah,
Dallas
that
approved.
So you don't even have to do it, man. I already set you up.
Thank you, Dallas approved. So I got some good feedback. They wanted to see more cultural foods. So I'm like, all right, I'm gonna look for more Asian foods. I have gotten some comments saying, "I'll try some more Indian food, like curries and stuff." So yeah.
That's how we met, right? Like I told them, like I saw ceviche, and I was like, oh shit, you know, like Peruvian ceviche.
Yeah,
not just.
just ceviche. I even make poke. Poke is amazing. But not everyone eats raw fish. That's okay. Get a ceviche. Yeah. Well, thank you guys. You can take the handouts if you want. If you don't, you can leave them. I can take them. No problem. I'll set off my back. But thanks for being here and have a good night. Yeah, thank you.
Some of them will see you on Saturday, Jonathan. There's
Oh, yeah?
a few that are, yeah, I think 4 of them.
Cool. All right, I'll show you guys Saturday.
Thanks, everybody. Have a good night.
Yeah, have a good night. And good luck, everybody.